So good evening, everyone. I am Dr. Mayank Dore, medical advisor at Dr. Reddy's lab, and it's my privilege to be a part of this webinar, the live webinar on the topic of a new addition to the armamentarium of COVID-19 therapies, Molnupiravir. And this webinar is conducted by IJCP and supported by Dr. Reddy's laboratories. And it's my privilege to introduce Dr. Agam Vora sir. Dr. Agam Vora sir is who will be moderating today's session. And let me give you an outline. We have two presentations, one by Dr. Gifty Emmanuel sir and other by Dr. Mangesh Tivaskar sir. So introducing Dr. Agam Vora sir. Sir is MD chest physician. He is consultant chest physician in Mumbai with more than 2 decades of experience. Sir is assistant professor in charge, Department Chest and TB, Dr. R.N. Cooper, Municipal General Hospital, Mumbai. Ex-professor, Department Chest and TB, KJ Somaiya Medical College, Mumbai. Assistant editor of Journal of Association of Physicians India, editor board member of Chest India, General Secretary of Academy of Advanced Medical Education, President of Geriatric Society of India, and Trustee of Malad Medical Association. So thank you so much for joining, and I hand over the session to you.
Mayank, you should have introduced Agam like this, you know, that here I introduce one of the most handsome pulmonologists from the city of Mumbai, who has been the heartthrob of JJ Medical College. Grand Medical College, rather, JJ and a Grand Medical College.
Handsome
darling of most of the and one of the most happiest and one of the most well-read pulmonologists of the country. And he is an upcoming secretary-elect of Association of Physicians of India and Indian College of Physicians and PRF, that is Physicians Research Foundation. Presenting to you, Dr. Agam Vora.
Wow. Thank you very much. Thanks, Mayank, and thanks, Dr. Tivaskar, for those nice words of introduction. Now, everybody knows your sense of humor. You know, when you call somebody like me handsome, you know, you can see that rich hairline and the multiple colors that God has given me. But anyway, thanks a lot. It makes me feel really better. Good evening, everybody. It's my proud privilege to be here on the same platform where my close friend, Dr. Mangesh Tivaskar and Dr. Gifty Emmanuel are there. I must thank IJCP and Dr. Reddy's for getting me here and giving me this opportunity to connecting with all of you here. As I understand, there are going to be a lot of physicians, a lot of chest physicians, a lot of COVID warriors who are interested in treatment of COVID are going to spare that Saturday evening to be here with us. And trust me, it's only because of your presence we are encouraged to do this program. IJCP is an academic group which was led by another legend, Padma Shri, late Dr. K.K. Agarwal. And I had the fortune of being with him on a couple of occasions. In fact, I remember, a couple of days ago also, I was thinking about him and I remember doing last few programs before he left us for his trip heavenly abode on the topic which was very close to our hearts, both of our hearts. He and me both were very much fond of this topic called immunity. And I remember when he was here a couple of years ago, and we were developing a document on doxycycline, and the way he connected modern science with mythology made me spellbound. I'm very happy that the group has continued the legacy, continued to serve medical fraternity with the equal enthusiasm. I must also thank Reddy's for their educational partnership, and I'm associated with them again for more than a decade and got chance to do a lot of programs with them. And then we have two giant speakers. How do I introduce them? I have the pleasure of introducing Dr. Mangesh Tivaskar, my close friend for more than 2 decades. Trust me, not a single morning when I've not spoken to him. The minute he gets out of his house, the first phone call, we have it with each other. The whatever medical problems I face. And the one solution is Dr. Tivaskar. And that may be one of the reasons why I'm so poor in my medical knowledge. Apart from respiratory medicine, I know nothing of medicine because Mangesh is there. He's a consultant physician and diabetologist serving Shilpa Medical Research Center at Daisar, Mumbai. He is the secretary of Association of Physicians of India, one of the busiest associations of physicians. He is very active member of American Diabetes Association, member of European Association for Study for Diabetes, and also serving Indian College of Physicians. He has received n number of fellowships from multiple international societies. Recently, he received his fellowship from Royal College of London, also Ireland, and also Edinburgh. Last 1.5 years, he has received 3 international fellowships. I remember when I was going through his CV, he's got 6 gold medals during his graduation and post-graduation. He was one of the loved students of his teachers and one of the very popular speaker among national and international conferences. That's my close friend, Dr. Mangesh Tivaskar. I also have the pleasure of introducing another giant, and that's Dr. Gifty Emmanuel. Sir is the infectious disease specialist, and he is MD, PhD, and virologist at the Director Center for AIDS and Antiviral Research. He's the director of Medical Division of Synergia Pandemic Foundation and former director of CSIH Hospital at Bangalore. I had the pleasure of being with him on a few occasions on the same platform, and I was thoroughly impressed by his ideas and his views on various topics of concern. Today's discussion is going to be very interesting, and we are going to be talking about Molnupiravir. Trust me, the COVID journey for last 2 years has been very interesting, with many ups and downs. It costed us a huge cost, lives. Yes, we lost almost 1 life every minute for last 2 years. We lost almost 1 doctor every day in the fight against COVID. We've lost almost 2,100 doctors who were fighting COVID. First time ever in my medical career, I witnessed such a huge pandemic. First time I saw a huge war with almost no weapons. I remember when we started treating COVID, Mangesh and myself work in the same area. We are in the Mumbai, the western suburb of Mumbai. And those patients started coming in, and we were having no medicines. We did not know whether we are allowed to treat this patient. We did not know how much of isolation and what kind of care and the hypercoagulability, and so many new things came up. For the first time, I saw a virus actually acting as an antigen and leading to not only viremic phase, but leading to so much of hyperimmune phase, with so much of cytokine phase that patient would eventually be pushed into cytokine storm, and to the extent that you may lose a few patients in that. For the first time, I saw a disease leading to such hypercoagulable state. For the first time, I saw so many repurposed drugs being used for COVID. Right from multivitamin to trace elements to old antibiotics to new antibiotics to old antivirals to new antivirals to steroids to biologics to what not, everything we used. And then in victorious time, we got vaccines. And again, so many vaccination program completed in again record time. Then came the most interesting thing. First time I ever saw so much of noise about one drug. And this noise came both in medical field as well as in the social media. And that is about the drug Molnupiravir. I was so much thrilled when I read about this drug. For the first time ever, such unique mechanism of action. I'm sure Dr. Emil and Mangesh would talk to us about it, but the drug which gets incorporated into the viral RNA brings about the replication termination, the mechanism which was unknown to me, was very exciting to me for the first time. Trust me, therapy only for 5 days. Trust me, a therapy where you need no drug dose adjustment, be it severe liver disease, be it severe kidney disease. Imagine a drug where there is no drug-to-drug interaction. You don't have to worry about any other ongoing treatment. Drug that leads to no GI upset. Drugs that hardly any pill burden. I'm sure there are going to be different strengths available. And then you will have just 1 tablet morning, 1 tablet evening. And trust me, in last 30-35 patients that I've used it, extremely well tolerated. When I look at the studies about this drug, I realize the drug has a potential to end pandemic if used wisely, because it can lead to early viral negativity and hence less and less viral shedding. But in some report somewhere in the lab, there came a big scare about mutagenicity, and everybody's mind got diverted to this mutagenicity. So let's hear from Giant's mouth what they have to talk about this particular molecule. To begin with, I would ask Dr. Gifty Emmanuel to give his first presentation. Dr. Emmanuel, over to you.
Thank you, Dr. Agam Mora. It was a fantastic beginning of this afternoon session. Great introduction, and so happy to be on the same platform with India's probably most eminent pulmonologist and very down-to-earth person, Dr. Agam. Thanks for the beautiful introduction, and my co-panelist, who is a stalwart with API, very close associated of my mentor, Dr. Arulraj, and fellow panelists for the day, Dr. Snehal of Reddy's lab, and everyone who was instrumental in organizing this program. So we will go through a PowerPoint presentation. Then with each PowerPoint, I will go into that caveats and whatever we have to add to the body of knowledge. And then we will have Dr. Mangesh presenting it, and followed by discussion and questions. Whoever would like to will be happy to answer. So Saurabh, can we have the slides, please?
Hello?
Yes, Saurabh. Yeah.
Yeah, sure. Yeah, I'll be presenting the slides.
Yeah. Kindly maximize it. So good afternoon, everyone. It's a fantastic day and a great way to start a topic on antiviral drugs, and in particular Molnupiravir. So the armamentarium of COVID has been limited from the beginning. We were very much in wait for a directly acting antiviral, which could inhibit the virus and stop it in its ways. Unfortunately, we, in the early phase of the pandemic, as a zoonotic coronavirus from an ancestral bat virus made way into the human population, it was almost impossible for us to come up with any antiviral which will have a direct effect on coronaviruses. So we had to repurpose drugs which were used for veterinary science, like remdesivir, which was used in cat peritonitis, feline peritonitis caused by a similar strain of coronavirus. We needed to bring in drugs which were indirect antivirals, like ivermectin, which has been tried a lot, and similar drugs with drug screening in silico using computer animation and modeling and bioinformatics, and also in laboratory studies, if we can get a molecule which will inhibit the virus at different stages of interception, which you can do either by inhibiting the viral molecules, enzymes like polymerase, or introducing errors in its replicative cycles so that the virus becomes replication deficient, or inducing cellular apoptosis of the cells which are infected with this virus. We were trying all the antiviral strategies, screening of drugs, repurposing of existing drugs, and looking for new molecules which can work on the COVID virus. We didn't know where it came from. Even today, the etiology is very obscure, but all we know is it is highly possible it was a bat zoonotic virus which jumped into the human population, and definitely the lab associated infection, or LAI, cannot be also ruled out because there are a lot of telltale signs that it could be having a malignant origin. That aside, we will be dealing with the antiviral today. So next slide, please. Now, we'll be going through what is the current scenario of COVID. So before going into the COVID metrics, I would like to say this single virus, which is responsible for only, it has got a mortality rate of only 3%. It's not Ebola virus associated disease, which has got a mortality of 90%. It is not Marburg. It is not Case-Nord forest disease. It is a simple coronavirus with a mortality less than 2 to 3%, but it has held the whole world ransom. And every milestone we achieved in global health has been reversed. With the advancement, what we had with smallpox, what we had with polio, what we had with the eradication of so many infectious diseases, including bubonic plague, we have right now come to a stage or square one once this virus has come into the foray. It has caused, according to WHO, excess deaths every year, the mortality, excess of the usual mortality, and many of the statistics are in a way an underreporting because half the COVID deaths are not even recorded properly, either due to deficiency in the system or lack of recognition and many other factors. So the problem here is every death due to COVID, as Dr. Agam clearly said, we have lost 2,100 doctors in this country and so many more in other countries also. So every death due to COVID is a failure of science, and it is a challenge to medicine. Medicine and science are at crossroads now, not knowing what to do with the cases which are increasing. The future is very bleak. We do not know what is happening. There are reports saying there is a strain which is lurking around, which could be much more virulent. The virus is adopting all strategies possible. Vaccines are becoming less and less efficacious. We are trying new generation vaccines. We're coming out with universal vaccines. We are coming out with nasal vaccines, which can produce IgA-based response and cause sterilizing immunity. We are coming with a plethora of immunotherapies or immunoprophylaxis. But what is equally important, and in some cases more important, is chemotherapy. We still need to have a chemotherapeutic agent or a drug or a directly acting antiviral, which will eliminate this virus at the earliest possible time frame. The current requirements are Molnupiravir is recommended for cases which are high risk, cases which have the high probability of passage into complicated stature or which will require hospitalization with ICU management. But at the same time, we need to look into several other corollaries before we come to a conclusion on the usage of Molnupiravir. Next slide, please. So as you can see, COVID-19, it started in 2019 as a simple outbreak in Wuhan province of Hubei in China. It was initially suspected as just another SARS virus similar to what broke out in 2003. And soon the genomic sequence was displayed by the Wuhan Institute of Virology. It became more clear it's not going to stop within the mural walls of China. It will extend way beyond it. So even an organization like WHO was hesitant to label it as pandemic because there are very few organisms which can get branded as pandemic organisms. For example, pandemic recombinant flus, plague, bubonic plague, and even Ebola virus didn't qualify as a pandemic pathogen. Cholera and few others can be labeled as it's handful of organisms. So when a new virus joins that repertoire of organisms, which are called pandemic organisms, it's a very hard decision to make. So that puts the human race itself at risk. To begin with, we need to agree when life formed in this planet, viruses played a key role in integrating the genome of human beings. It was as a genomic integrated, it was able to bring in and build our genomic sequences. So viruses are very capable, and their deceptive simplicity is what makes us kind of underestimate their potential to cause damage. So right now, we know every country on this planet is affected. There is no country which is not affected, and the strains keep variating. We get quasi-species of the virus. The viral subpopulation is spreading, and at some point in time, there'll be so many strains, we would find it very difficult to even mention all those strains put together. And there is also a dire possibility of recombination within these strains. For example, if two different strains like an Omicron or a Delta plus infect the same person, recombination and swapping of genes between viruses can happen. Then offspring can have qualities which are previously unseen in the parental virions. So that is a very, very risky proposition. Next slide, please. So as you can see, these are the case distribution throughout the world. United States is still one of the most affected countries. Initially, we had a lot of fatalities in Italy. It was really, really bad. One reason was there was a lot of migrants from Wuhan who went back to Italy and came back, and they had hug a Chinese a day concept in Italy, trying to integrate Chinese migrants. And that was suggested as one of the causes where interpersonal spread happened highly in Italy. Russia, of course, vaccine coverage is not as good as other countries, and statistics might not be very clear compared to other democratic countries. And United Kingdom, of course, they had a lot of fatalities with the Kent strain or the Alpha strain. And right now, Delta also swept through United Kingdom a lot. Brazil was one country which had a lot of cases, and their experiment with convalescent plasma led to what we call as surgeons in a particular strain called Gamma strain, which was a little more lethal than the current strains, of course, less lethal than Delta. We were thinking that could be a great threat, but somehow Delta took over, and rest of the countries. So two great democratic nations, India and United States, are extensively affected by this virus. And the statistics can be sometimes not so accurate and precise, because nowadays home testing has come, rapid antigen kits are becoming more and more sensitive. So it's highly likely that people are not reporting cases, and these kind of slip-throughs in epidemiological patterns can definitely happen. Next slide, please. So as you can see, there is a clear graphical representation of how many million cases of COVID is there, and how it is transitioning from early phase to the current condition. And as you can see, pandemics do not follow a very straight trajectory. They can be in like a sine wave, ups and downs, periods of rest followed by period of exacerbation, and then coming back to the baseline. So that can lull us into a sense of false security, thinking the pandemic is gone. But that's how every pandemic has operated. It doesn't follow a very straight path where it becomes very predictable. They always go in an up and down, a blip, and then a crescent and a downfall, and then again a blip. That's how usually the graphical representation of any pandemic is. Next slide, please. So as you can see here, there are certain seasons where the COVID virus peaking is more, and in certain season it comes down, and that in certain times of the year. These are basically winter propagating viruses, in the sense that atmospheric ambience can greatly aid in the transmission. Even in Wuhan, it was a cold winter when this propagation happened. Summer months have a mild inhibitory effect, but still the virus's environmental survival is so high compared to any other virus. So we can't take that environment as a detrimental factor. However, hot climates does have a mild inhibitory effect on the propagation of this virus. Next slide, please. So if you can see this graph, we have the total number of corona cases and active cases which are resurging, and it does vary between the waves. For example, the original strain we had as Wuhan was very different in its manifestations compared to Omicron. Omicron, for example, is very mild compared to Delta plus, Gamma, and Wuhan. However, BA2 strain, or the sublineage of Omicron, can cause desaturation, and the second week onwards can cause a cascade of immunological reaction, which we understand as the immunological phase of the disease. So it is capable of creating that kind of changes. So Omicron itself cannot be taken very lightly. And as we all know that nobody is in 100% health, there are people who live on borderlines, and these are people who have comorbidities or genetic susceptibilities, overt immune reactions, and these are the people who will take the tipping of the balance when Omicron or any strain of corona infects them. So in fact, when you look at the large statistic, Omicron has caused more deaths than Delta. The very simple fact is the viral fitness and adaptation of Omicron and the evolutionary choice of Omicron is much more successful for the simple reason Omicron doesn't engage your immune system. That is a very superior viral strategy of handling the adversary. Instead of engaging and causing collateral damage, the viral virus way of handling the immune system is circumventing the immune system than engaging and losing itself. So that is a superior strategy, and Omicron is able to very usefully or very capably do that, and then extend its lethality by either recombining with other viruses or causing sub-strains of Omicron, which can be much more lethal. So we cannot take it as lessening of the pandemic or a precursor to an end. So that will be wrong interpretation or even misreading of the pandemic's trajectory. Next slide, please. So this is again how the total number of deaths happen over the years, and we have had nearly 3 years of this pandemic now, and there are people who are infected multiple times. I've known doctors who are infected 2 or 3 times. So what does happen to such people? Do they have more enhanced autoimmunity? Do they have more of scarring, which the virus leaves behind? Do they have increased fatality or decrease in fatality? So a lot of things to be thought after. Next slide, please. So although recoveries are very good with a strain like Omicron, literally 98% are making full recoveries, we still haven't documented the entire disease completely. Let us say we juxtapose this to leprosy or tuberculosis. We know what the disease is. We have been with it for nearly hundreds of years. And through all systems of medicine, we do understand how a natural history of the disease progresses. But with corona, we do not know what will happen to a COVID patient 10 years from now. What will happen to the lung fibrosis? Does it cease and reverse and become a normal architecture? Does this pathological change form the bedrock of future metaplasia? We really do not know what will happen. Similar with cardiovascular conditions, changes in autonomic rhythmicity, hypercoagulable state, even after discharge nearly 3-4 months later, myocarditis, and a lot of things we are clinically seeing. So these recoveries which we see from COVID, although they are very heartwarming and encouraging, we need to take it in a total context than a snapshot view saying everybody who gets infected is happily recovering. It is not so. This is where the antivirals can come in the sense usage of an antiviral in a high-risk group might some way mitigate the development of future complication because it cuts the viral antigenemia, as Dr. Warren earlier mentioned, that virus can act as a super antigen, and this antigenemia can trigger low levels of inflammatory response and autoimmunity. So if we cut this viral antigenemia very early in the course of the disease, will that kind of mitigate the entire spectrum of long COVID or the secondary complications of COVID? Are interesting arenas worth exploring. Next slide, please. So this is the classical definition where we have mild cases occupy the major chunk of the disease, and the severe cases are 14%, and critical cases are 5%, which will definitely require oxygen assistance, intervention with all the other set of drugs from Regeneron like monoclonal antibody cocktails to immunosuppressive drugs to pulse doses of steroids, so that we are able to dampen the reaction or cytokinemia or T cell launch of cellular chemicals which can cause organ damage and shutdown. A condition very similar to high-level sepsis, which we often see in non-infectious conditions, non-COVID conditions rather, in the ICU. So this kind of exaggeration or increased immune response is very hard to detect on day one. Although the guidelines tell us that antivirals have to be given with high-risk cases, we also as clinician needs to be a little flexible with that definition, in the sense, how do you decide on day one if this person will progress into high risk? Of course, comorbidities are clear on day one, but the other factors, will his immune response be something which will go very high? The disease can be defined in a very simple manner as the interaction between the host and the agent. So if the host is tolerant to the agent, there is no disease at all. This is what we see in bats. The bat's immune system is so very evolved. It has become so well modulated. All the energy of the bat is sent to its flight. Since it's a flying mammal, every energy is dedicated to flight and very little resources are allocated to the immune system. So the immune system does not respond to any virus, whether it's rabies, whether it's Lysa virus, whether it's Ebola and filoviruses, or coronavirus. It doesn't respond to any of these viruses. It just has learned to tolerate. And then humans are also able to do that with cytomegalovirus, herpes virus, and Epstein-Barr virus. If 90% of the population is tested for, sero-tested for CMV, we'll all have IgM, IgGs heavily. So we are learned to kind of accept this and coexist. So it is the immune response of each one which really lands you in a severe disease. So it might not be possible in the first week to decide this person is going to overreact. So does that mean we blanket prescribe antivirals for everyone? That may not be the case, because affordability and clinical choice of cases criteria, all those things need to be followed. So that is left to the physician to decide and make a brilliant and an astute decision who is the right person to get the drug. But using this drug can definitely mitigate some of the later complications of the disease. Next slide, please. So these are the subvariants and variants of concern, and Delta, as we know, it was from India, similarly Delta plus, and Omicron we believe could have been from sub-Saharan Africa. The theory is that someone who was HIV positive and was not on antivirals got this drug and jumped back. And we shouldn't forget there is a huge zoonotic reservoir. Recently, a couple of days back, there are reports which are emerging that white-tailed deer in New York area, many of them are infected with Omicron. So even if we eradicate Omicron from the human population, there is a remote possibility that an animal reservoir could be out there. Next slide, please. Next slide, please. So regarding the management, this is the holy grail of the management of COVID. How do you really manage COVID? So there are a plethora of guidelines from, CDC, from WHO, from Indian Council of Medical Research, our very respected API, and many other guidelines are out there, and many of them are interim and they keep updating. So you are given very nice outlines and clear norms on how you go about COVID, and each guideline with each new version, so much of improvement and so much of adaptability is there, which is very, very interesting to note. Next slide, please. So how do we go about understanding the virus interaction? To begin with, the early viremia phase is the phase when somebody is incubating the virus, what we call as the prodromal stage, and then it comes to the clinically active symptomatic stage. That's when you see the reversal of LNR ratio, your rise in D-dimer, the inflammatory markers like C-reactive protein, calorikinin, bradykinins, and all the markers of a highly atherosclerotic or a thrombotic stage exists, added with hypoxia and the stress of the disease itself makes it an ideal cocktail for death and cardiovascular and vascular events. So that is a stage which is a very, very serious stage. And then over a period of a week, the immunological phase kicks in, and of course we have the in between the pulmonological phase or the respiratory phase, and even in that pulmonary phase the virus behaves very differently. There is a generalized understanding that Omicron doesn't cross your upper respiratory tract, it remains within the throat and doesn't come down, but electron electron microscopic pictures are saying otherwise. The viral load of Omicron in the lung tissue is far higher than Delta. But the pathogenicity or the severity of Omicron being less, it doesn't cause much of lung manifestation. And then the hyperinflammatory stage or the immunological response is huge. Like a judo player, the virus is able to turn your weight against you. It is, in fact, our immune system which kills us. It's more like an anaphylactic reaction, where more than the small penicillin molecule which triggers the anaphylaxis reaction, or a groundnut which creates that anaphylactic reaction, the surge of histamines, bradykinin, and all these molecules kill a human being. Similarly, in this infectious disease, it is the immune response which kills a person than the viremia itself. The viremia at the maximum can cause seeding. And second most important thing about COVID, it's a recent finding, 300 days after COVID, some people who had died due to non-COVID causes, when their bodies were completely studied and they did tissue level studies, and they were able to find viral particles 300 days after clearing COVID. That is nearly a year. So this viral excretion and viral seeding are two things which you need to be very, very careful about. The original zoonotic pathogen from bats excretes through its cloaca or its opening, and it infects the other roosting bats. That's how it propagates from one host to the other. The same thing it does in a human being. But the point of interception here for a doctor is to administer the antiviral drug so that the seeding of the virus doesn't happen into many, many tissues, like your neural tissue. It's a neurotropic virus. That's why your olfactory and other things are affected. It can affect your endothelium, interfere with nitric oxide and all those neuroconductive chemicals. It can interfere with any area or any organ which is called AC2 expression, and this includes the kidney, your large part of your intestines, your myocardium, pericardium, every other organ, including the skin, can be affected with the COVID virus. And this is called the seeding. The virus is able to disseminate beautifully once you allow it to disseminate. Our point is, how do you even block it at this point of interception? That is the most crucial thing. And for that, you need an antiviral. Next slide, please. So the disease progression, as you can see, it starts with early phase, and this is the phase where this replication is severe, and this is the time when antivirals can play a major role. And when it goes to the second week or the third week in extended cases, antivirals might not be very, very, very significantly useful. When the seeding is there, when there is dissemination, when there is proliferation of viremia and the replicative cycle is active, this is where it has to happen, and why we have to intervene at this stage. So this particular drug has been very well approved by the Drug Controller of India, and many doctors who have prescribed it have found it to be effective in the early stage. So to give an antiviral or not to give an antiviral, for example, is a big question right now. There are a lot of schools of thought, lot of doctrines of understanding antiviral therapy, but from a practical viewpoint, it is always better to intervene early with an antiviral which acts directly on the viral replicative cycle. The virus is very, very smart. Most of the coronaviruses of other animals do not have a error corrective mechanism. So when we create errors in its, the amino acid sequence, A, T, and G, and C, and all those things, what really happens is the error remains an error and the virus becomes replication deficient. But with coronavirus, when we create those errors using molecules like Molnupiravir, it can correct it with the error correcting enzyme, which is very unique of this particular coronavirus. The proofreading mechanism is very much there, which is usually absent in most of the RNA viruses. There is no proofreading. So you need to create a massive error in this prokaryotic cell so that you create, a real change in the genetics of the virus so that it becomes replication deficient. And for that, a drug like Molnupiravir, which induces mutagenesis or inhibits the nucleic acid chain in the virus, is very, very important, because just replacing those molecules is not enough, because excision and endonucleases of the virus can always recheck your error and correct it, especially in SARS-CoV-2. So we need a virus inhibitor or an antiviral which is able to overcome this process, because there are a lot of places in the life cycle of the parasite, the virus here, where we can intervene. One is inhibiting the viral enzymes. Another is preventing the fusion to the AC2 receptor. Another is preventing budding of the virion from the endoplasmic reticulum and the cell membrane. And another is preventing viral transcription. But many of this may not be very effective. But when you introduce mutagenesis into the virus's genetic structure, it does replicate, but it becomes ineffective in causing serious pathogenicity. That's where this molecule could excel in that arena. And I'm sure Dr. Thevaskar will explain in depth about the concerns regarding toxicity and clinical adverse reactions. So, this is a very important strategy, a very important antiviral strategy. Why this drug will be very pivotal in making a change in handling this particular coronavirus, because of this molecular mechanism behind which can be a very important area of intervention for chemotherapy, and early intervention can result in lowering viral load. And there is another interesting point I would like to make is, we are always used to a template of antibiotics. Suppose somebody comes to with a urinary tract infection, 100,000 organism of E. coli, you give them nitrofurantoin or a quinolone, and few days later it becomes no growth. This is a template for antibiotic usage. But with antivirals, it need not work in the same fashion. It need not work in the same fashion. These are not two similar categories of drugs. These are two different categories of drugs, and they need not work in the same fashion. The classical example is acyclovir. Coral extract, acyclovir, is a virostatic drug. But when somebody has a cerebral infection, neurotropic infection, or Ramsay-Hunt syndrome, or disseminated things with the herpes virus, we always give acyclovir. It makes a world of change. We do not look at it as a virostatic drug. So antiviral drugs work very differently from what we call as other drugs. And we need to understand the mechanism in which antivirals can help the immune system and the body clear the virus or subdue the virus into a non-replicative stage and slowly eliminate it from the system. They need not work like antibiotics, for sure. And the viral mechanism of resistance and inaction is also very different from what we see in antibiotics. So this is a different class, requires a different relook at the principles of antiviral chemotherapy. And secondly, nowadays 4 capsules are being given morning and evening. And soon, like favipiravir, which was launched as 200 milligram, very difficult to give it for people. Patient compliance was bad. Then they were able to put it into 800 milligram. I'm sure in a very short while, they'll be coming with a single tablet. I'm sure it was already told. So when it comes into a single tablet, patient compliance and ease of use is going to be very, very good. And in a pandemic setting like coronavirus, intravenous antivirals might be the choice for a select few who are very severe in the scale of the disease, and oral will be the best way to really address the thing on a large scale. It can prevent your secondary transmission. It can reduce your domestic transmission. It could make you less infectious. It could also prevent the disease from becoming serious or even moderately serious, and prevent secondary complications. And I also firmly believe the viremia, which happens in a slow level and it extends up to nearly 200 or 300 days in some cases, can be blocked very early with this particular intercept we are able to do with this directly acting antiviral. And I have seen this happen in other viruses like hepatitis C, where we use velpatasvir, sofosbuvir, and all those drugs, or with HIV, a very similar molecular mechanism. So if you have been treating viral diseases, you understand corona is no different from them. The only thing is we will not hesitate to use antiviral drugs, and they can have a direct implication for the control of the disease. So with Molnupiravir, I feel that is that is a key drug which can intervene at different points of viral replication and reduce the viremia at early point in time. And compared to many other drugs which are on the pipeline, like protease inhibitors, Paxlovid, which is a nirmatrelvir with ritonavir boosted. These are drugs which we have been using in HIV care. And even tenofovir and emitricitabine, which we have been using very successfully for HIV, and even as a pre-exposure and post-exposure drug, can also inhibit nasal viremia due to COVID-2. So these kind of drugs are also being considered. But comparing to those drugs, protease inhibitors, I feel Molnupiravir is much more on the safer side and easy to administer, and not much of any major adverse reaction. Next slide, please. So importance of early intervention cannot be underemphasized. We all know FIT and the filtration of the mask. These are two Fs we need to be careful. There is an N99 which is available right now, which you can use it. And hand hygiene and other things, and physical distancing. There are some studies which say the virus can jump up to 28 feet, but officially we are maintaining at 6 feet. And ventilation, of course, if there is a lot of airflow, which we call as air exchange, industrial hygiene, we call it as air exchange. If the number of air exchanges in the room are very high, the chance of viral spread is definitely very, very low. And of course, vaccination and avoiding of places of mass gathering, like places of worship, meeting, weddings, and other things need to be avoided, so that we prevent transmission of this virus. And again, and a very vital point with antivirals are vaccines take time to be developed for each strain of virus, to be inclusive of them. For instance, if there is a new Omicron vaccine which is being developed, but for an antiviral, the strain doesn't matter because it goes into the molecular level and intercepts the virus. So comparing it with the antiviral vaccine, antiviral drugs are a boon in the sense they can be administered to any new variant which comes in. You don't have to wait to see its genomic sequence. You don't have to look at its external morphological epitomes. You don't have to look for the way it behaves. Anything which inhibits a particular enzyme or creates mutagenesis or interferes with the replicative cycle will work eventually in all variants. So that is one thing which we can very rapidly use when we are on an arms race with the virus, which is beating at every step. So we need armamentarium. We need an arsenal which will address that. Next slide, please. So this is a management strategy. By now, I'm sure everybody knows this, how the virus goes and comes down and it keeps shedding, and where are the onsets of symptoms possible. And of course, the complications can be late complications also, and the treatment possibilities, and the best way to, or the best time point to intercept this process, the linear process, and block it is that the earliest phase. After that, antivirals might not be very, very effective, and they are not recommended either. If you are going to give it, you give it at the earliest stage. So access to an oral antiviral is always easy at any point in time during the window of opportunity, not to wait for any specialized tertiary care center or cardiac monitoring and other things when you're administering intravenous antivirals like remdesivir. Oral antivirals can be right away launched with a blip of an eye, and it doesn't take much of a rocket science to take an oral antiviral. So that is a big advantage in a pandemic scenario of using an antiviral. Next slide, please. So the mild disease can progress into a moderate and severe. This is like a chain. and it can sometimes cessate with the mild itself. It depends on the host and other factors. So the inflammatory process and coagulation pathways are the ones which cause the majority of the problem. So again, somebody goes into this phase, to reverse them to square one is very, very difficult. Sometimes it could be irreversible because some of the pathological process by its innate nature are not very reversible. So it's better to intervene much early in the cascade of inflammatory reactions. Next slide, please. So therapy of COVID-19 is largely looks a little complex, but it's very simple. You hit the thing hard, you hit it early, and that's the way you shut down the viremia, or at least make the replication very ineffective so that it is not able to elicit the immune response. Once the immune response is elicited, the quantum of viremia doesn't matter. It more or less progresses like an anaphylactic reaction. It could be a small groundnut. You don't need a ton of groundnuts. So all immunological reactions only require a minor trigger. So it'll be ideal that we hit it hard and early with a drug like Molnupiravir, then allowing it to extend for a longer period of time, and then interfering with the best of monoclonals and pulse steroids or immunosuppressive newer biosimilaris agents and other things. Next slide, please. So hit hard, hit early. And there is also an emerging concept which I've been also thinking about. COVID can have some kind of immunosuppressive effect. Although it is not a HIV-like virus, it can have immunosuppressive effects in the sense it can downregulate some of the most crucial immune responses, or the immune responses can be so hyper-regulated that it is dysfunctional at any state. For example, we saw a lot of mucor coming out of COVID patients. This activation of mucor, it's not just due to the use of steroids or because our environment is filled with mucor spores. It is also a reason there is a kind of a transient immunosuppression, and this kind of activation of what we call as opportunistic pathogens can happen in COVID. So we will not allow the patient to progress to that level where the virus is acting like a super antigen and causing all this kind of immune dysfunctions, hyperimmunity and hypoimmunity, where these exotic pathogens, which we don't see in routine practice except in end-stage diabetes or poorly controlled diabetes, or in highly immunosuppressed transplant patients, these kind of pathogens are getting activated. And once they get activated, we sometimes dose them with 50, 60, or sometimes 90 ampules of what we call as amphotericin B. Even if it is in a smoother delivery, lipid-laden form, it can have a lot of side effects and the cost and other things. So intervening early before immunity strikes against us might be the best strategy. And antiviral drugs are the greatest in that stage. And they can also prevent virus shedding. And it can do a great thing. It can prevent interpersonal transmission. Studies have shown this particular drug, Molnupiravir, can bring down the viral load within 48 hours. Favipiravir took nearly a week's time. So 48 hours is so very good in the sense the third day onwards, the transmission dynamics changes 100%. The next person, chances of the household contact contracting this virus is very low. SARS-CoV-2 is a highly infectious virus. We know in Hong Kong, in vertical apartments, even flushing the toilet can lead to aerosolization of this virus and transmission to nearly 550 people in the same apartment complex in Hong Kong. We saw that in SARS-CoV-2, and even now it's happening in many areas. So this kind of reduction in interdomestic and interpersonal and interfamilial transmission can play a significant role in bringing down the number of cases which are there on the whole. It can be a surrogate and a co-drug with any immunoprophylaxis like a vaccine. And it can really take the COVID control and COVID management and COVID prevention to the next level if we judiciously use this particular molecule in the management of COVID. Next slide, please. So now the question is, we are able to curtail the wave of pandemic. We can bring down this. We can address variants. We can prevent secondary transmissions. We can also reduce severity. We can intervene early. we can use this drug to work in areas where the vaccine is not able to offer that kind of hope. For example, secondary transmission, nasal viremia, which is again a precursor to transmission. So these are the areas wherein this antiviral can fit in so very well. So we need to take a multi-pronged approach. The virus is super smart. It is highly evolving. There is no signs of stopping. So we cannot use one arm of a therapy. We need to use everything in our arsenal so that we collectively bring this pandemic to a standstill, completely conquer it, and see that our race is completely redeemed from this pathway we are currently heading. I don't wish to sound bleak, but reality also has to be checked once in a while. This pandemic is a huge awakening for all our healthcare workers and physicians and scientists and policymakers, that this virus has really blown us by surprise. It has taken every single human being by surprise, entirely crippled a globe. And we are waiting for some kind of liberation. And if that is coming through an antiviral and combination with a vaccine and the time-tested public health approach of preventing disease by hand hygiene, distancing, and risk avoidance and using masks, that will be a combined, integrated, and a concerted effect for the greatest global health challenge of our times, that is the COVID-19 and SARS-CoV-2. So next slide, please. I think that's the last one. So thanks for your time, and thanks for bringing a great audience. And once again, thank you, Dr. Ora and Dr. Mangesh. It's an honor to be with you both. And thank you, Dr. Lerdy's team and Dr. Snehal. Thank you very much. Any questions, we'll be happy.
Great. Thank you, sir, for that wonderful talk.
Agam, what I think now we should do is this, that that we'll have directly question and answers. I'll have just show a couple of slides on how this drug was developed, and then probably we'll directly jump into the question and answers.
Okay.
So that we'll have
so Dr. Mangesh Tivaskar now suggests slight twist in the program. Yes. So we thought we will have another talk by Dr. Mangesh Tivaskar where he would talk to us about clinical trials that were developed and I mean what points were considered before
we need to have adequate time for question and answers. And there are going to be some questions.
Wants more question answers and more discussion. So we changed that sequence. Mangesh, to what's your plan? You're going to be doing some slides.
I'll just show you some slides. Where how Molnupiravir was a very interesting development. As Dr. Gifty has in details covered about the poles of management, and he has also placed very well where COVID and Molnupiravir stands currently and how Molnupiravir works. So I'll just give you a new antiviral drug which has made a sensation, and this is just a development timetable. This is very interesting, Agam, and you will be really intrigued to know that in 2013 it was Emory who started screening the possible RNA interventions while they were dealing with equine encephalitis viruses, and usually were used during the world wars as bioweapons. You can imagine an encephalitis virus was used through mosquitoes and various delivery methods to induce encephalitis, viral encephalitis. So that is the reason why this concept was taken up as the Defense Threat Reduction Agency of Emory, and they drew what we call it as DRIVE license. That DRIVE stands for the Drug Innovation Ventures at Emory. And they got the first license to develop this EIDD or Molnupiravir EIDD 2801 as a drug to develop a new possibly interventional and investigational drug against COVID-19 because of such an emergency which was on. And then, of course, Ridgeback along with Merck joined hands together, and they started their phase 1, phase 2, and phase 3 trials. And you'll be surprised that within an absolutely 6 months of time or a year's time, Merck submitted it for an emergency use authorization, which was immediately approved, and Britain was the first country ever to approve this drug. And then came the series of countries, including India. So very beautifully talked about the whole concept and how the pharmacology. And what I liked about this drug is that it initiates what is called as the catastrophe of error. This terminology I am really impressed with. because catastrophe of error, that means that the drug which neither causes any change in the metabolism or a substrate or an inhibitor. And I always was intrigued by this concept that in any microbe or a virus or a bacteria will ever enter the host in a quest to kill it, because that will rule out its chance of nutrition as well as the chance of multiplication. What actually causes the bug extremely badly deterrent to the host is usually the immune system, that as Dr. Gifty has already properly talked about. And this drug actually does the same. It, and the brilliant idea had come. I'm really intrigued by the scientist and the thought process, that a brilliant idea of why not to intervene at the time of once they enter at the time of multiplication and probably at the nutrition into the RNA. And that's exactly what happens when Molnupiravir is given, where it changes the sequence of the RNA while multiplication, and it causes what we call it as a transition of error. And then oximes and hydraulic oximes and the whole amino acid sequence changes from cysteine to uracil, or guanidine to arginine, and this kind of changes they happen which are not viable for the viruses. And that's how this drug has been found to be effective, right from the murine hepatitis virus to even all the variants of SARS-CoV-2, including the Delta. There are some promising results for even Omicron variants also. So this is the drug which is oral, which is less expensive, quick, and promotes the accumulation of error. And that's how it stops the multiplication and further progress. This is the drug Molnupiravir. Over to you, Aga. Thank you very much.
Wow, that was fantastic. Very crisp and perfect message that you gave. Mangesh, so let me start asking you this question. Why there is so much of confusion, so much of noise level about this molecule, which has never happened in my medical career of last 25 years? Why people are so much talking about this molecule on social media over and on?
Yeah, it just happened primarily because of the fact that probably, on one of the television interviews, one of the, doctors and one of the company man has spoken accidentally about the possible mutagenesis, and it became viral all over. And all today's social media, people are brilliant enough to draw inferences. They use their own, acumen to interpret and also draw inferences and immediately start posting. And because of the freedom of I would say writing, everybody is free to write down their own inferences.
And thanks to the social media, news spreads so fast,
so
and that too negative news spread faster than probably the
and that
positive
is
news.
Yes.
So in that continuation, let me ask you this. Now, with whatever available knowledge we have, whatever the setbacks that we have, whatever mutagenesis concepts we have, would Dr. Mangesh Tivaskar use Molnupiravir? And if he going to use it, in what kind of situation is going to recommend it to you?
100%. I am going to use it. And as you have that initial experiences, my initial experiences with nearly 55 patients that we actually have treated during this COVID times, if you remember, Agam, that, Molnupiravir has been successfully used in the patients, those who are, progressing, not really a mild case, but even though I wish that I would have had that freedom of using it, but I still will follow the ICMR and most of the global guidelines, and I'll stick to that concept that yes, in the patients, those who continue to have fever, the patients, those who have got associated comorbidities and are likely to go into the complications, the patients, those who are elderly and at a higher risk of having a hospitalization, probably I want to stop them early. So I'll probably, I'll take up these patients as the patients, because this drug is so safe. It's so safe. It doesn't have any I would say impact as far as the hepatic or the renal challenges are concerned. It's extremely safe in most of the situations. The only probably contraindication here to use is currently pregnancy. And as you talk about the mutagenicity, probably there are so many mutagens that we are exposed to in everyday day-to-day life. So just 5 days or 3, 4, 5 days of exposure to this drug in such a pharmacological dose. So we are not talking about even experimental dosages. We are just talking about the pharmacological dosages. I don't feel so that should be a matter of concern. And as the viral and the whole usually genetic systems are overturned, Really, over a period of time, naturally, each and every cell of our human body is going to get overturned, and the genetic sequences are really, they die, the new genes and the new sequences will form. So I don't have to be really worried about that, honestly.
Good, interesting. Dr. Gifty, are you there? I was just thinking of a
Yes.
situation. Every cigarette that I smoke, I mean, not me, one smokes, probably has got multiple mutagenicity, multiple carcinogens there. What are your views on it? 5 days of
Yeah,
molnupiravir, you think will have any long-term impact on anybody?
that's a fantastic question, Dr. Agam. Basically, the drug targets the prokaryotic like cellular organization than the human cellular organization. In the sense, it is aiming to intervene with the viral replicative cycle, not with any human replicative cycle. So it is aimed at a more or less, we can call it in a way as a unicellular organism than at the human genetic code or anything. So the possibilities of such a transition causing toxicity into human beings are quite rare. In that case, even many of the drugs like metronidazole, what we use, is a carcinogenic drug. It says even on the packaging, it says even on metronidazole creams, which are used as topical things, it says carcinogen, mutagenic. So as Dr. Mangesh clearly pointed out, a short span of time of 5 days is not going to cause any kind of damage. And secondly, of course, people who are expecting to be pregnant or who are in a reproductive age expecting some kind of conception, or a male or a female who's planning a family, can always use other options or delay their reproductive attempts and other things. So this particular drug aims at the viral pathogens genetic code reassortment, not the human genetic code. So they are two different.
Perfect. So Mangesh, in today's time, this mild COVID. Now tell me, I give you two situations. You have a mild COVID, that means patient is symptomatic, a young patient and an elderly patient. A young patient with comorbidity and elderly patient with comorbidities. Would you use molnupiravir?
Yes, of course. Anybody who has got comorbidities and has a tendency to progress,
Correct.
I'll use it as a first chance to. And believe me, Agam, and over a period of time, as our knowledge has been changing, I'm more than sure about it. As we have, evolved our knowledge. Now you're talking about, initially, if you remember remdesivir, there was so much of no for this. There was so much of inhibition for it. But then over a period of time, as our knowledge changed, as our approach changed, and as the drug has proved its safety, remdesivir, the fear was gone, the availability was not a challenge. Everybody was happy to take it, and there were no further discussion happening, not in between the medical communities as well, and as far as doctor and the patients are also. And I'm more than sure about it. As we had the same thing, do we ask any questions when you write down priorly Tamiflu to the patient, oseltamivir to the patient? No, not at all. Do you ask any question when you write, or do the patients ask you about when you write down acyclovir to the patient? Not at all. Or any anti-HIV protease inhibitors, or any nucleoside antagonists that you write down to the patients? Do the patients, they ask you about it? No. In fact, these are the patients those are taking these antivirals for life. For hepatitis C, for hepatitis B, patients are taking it for life. Here we are taking the drug for 5 days. So why not to hit hard? If you're really totally bothered about the transmission, even though the guidelines, they do not support it, let's just start thinking about a new idea. And what is wrong in that? That can this be a drug which can be explored in an early use, even in the patients where there is a documentation of a virus which is present? You talk about transmissibility, you talk about the community involvement, you talk about the infectivity. There has to be some methods to stop it. We are following masks, we are following sanitization, social distancing, all those cultural beliefs and all those very meticulously. But then are you really able to stop the viral shedding? Probably this could be one of the interventions which may turn out to be, even though it is currently not. I'm more than sure that Snail is not happy with me when I'm talking about the very early use. But I'll tell you that, Snail, believe me, as our knowledge goes up, and I'm more than sure about it, you'll realize that what we discussed on this forum, what Agam believes, what Dr. Gifty believes, and what I myself believe personally, is this: that yes, probably these drugs can be even used quite early than probably we are thinking it.
Great. So that means what Dr. Tivaskar is trying to tell you is your disease can do more harm than what your drugs can do. It can really save lives. And probably in last 50-55 cases that Mangesh stays in, about 30-35 patients that where I have used it, trust me, we have found no side effect. This drug is tolerated extremely well. You don't need any dose adjustments, even with liver derangements, even with kidney dysfunctions. Even if patients are on dialysis, you could continue using the drugs in the same dosages. Only 4 tablets, 200 milligram, 4 tablets in the morning and 4 tablets in the evening for 5 days is what is recommended. Dr. Mangesh Tivaskar and myself are developing a position paper on Molnupiravir, which we are likely to request JAPI to publish it, where we are trying to position Molnupiravir in today's time. And Mangesh, would you throw some light on it? I mean, those 20 questions roughly, would you talk about it?
Yeah, we came out with almost 21 questions on all the aspects of COVID, and there we discussed about almost every possibility, including the post-exposure prophylaxis of very high-risk individuals in pregnancy, in the sexually active men, in the would be possibly or young married women, as Dr. Gifty was talking about. All these questions: pregnancy, lactation, even early use in the uncomplicated cases. Every possible exploration that we are trying to do, and we have developed a questionnaire on that, and we are going to have it. Our core committee has already developed and approved these questionnaires and the answers to it, and also we are going to now disseminate this into the physician community, and we would be requesting the physicians all over the countries, and we are going to gather that, and we will come out with a sort of a white paper or a position paper. With
Dr. Emmanuel, we would send you that questionnaire. You also please have a look and yes, guide us if anything else needs to be done. And I was very much fascinated when Dr. Tivaskar did an in-depth study, and he said that the sexually active couple, there should not be any sex by male partner for 4 months. And then
I did not say that. I said that the barrier contraception is mandatory.
So barrier contraception can be done.
Yes.
So I don't know why he went into the details and why he really found out that, but this is what he said. So Mangesh, would you want to throw some light on it? Not yes, why you found out, but what you found out.
It is usually that for 3 months for a male. Now, my question initially thought was, why for males for 3 months and for women it is for 4 days? Usually. And then I realized that 2 things. While I was just browsing the literature, I realized that, it's quite possible that this drug can get into the germ cell genes. And that is the germ cell turnover is around 3 months of time safely. Ideally, it is around 28 days to 36 days, which has been mentioned. But to be safer side, where most of the new germ cells are available, it is usually the turnaround time is just like RBC is 3 months. And the second and the most very interesting fact is this, that there are highest number of ACE receptors in testis. Any organ in the body, if you really found out gram to gram wise distribution of ACE2 receptors, they are in testis and epididymis. That is the place where, and that is the reason why that was interesting.
In the discussion, there were 1-2 more points which came out, and that is for primary prophylaxis. And most of these members in the group felt that if you have, say, you and me, doctors, and if you are COVID positive, and if we end up taking Molnupiravir, probably your RT-PCR negativity happens faster, and you can resume to your work faster. So that is the one population where one could use this, even in mildly symptomatic patient or even in asymptomatic cases, so that you can return to work faster. That is one thing. Second thing is, all family members of RT-PCR positive. Suppose if I am positive, then all my family members who have high risk factors, who are elderly, mainly my parents and my grandparents, they can also be given this drug as a prophylaxis. And third thing which came out beautifully is, even empirically, you can start this drug provided you have a very high suspicion of COVID. So in the sense, if I am positive, if my wife is positive and my brother develops symptoms, even before his result come in, if he's the candidate with comorbidities, I think he would be the candidate for Molnupiravir. And these were the points that came out in that discussion. There are some questions in the chat box, and I would quickly take up because we've overshot time. Any possibility of 800 milligram capsule? Yes, in some time we are going to get 800 milligram tablet available, capsules available. That would make it very easy. 1 tablet morning, 1 tablet evening, and 5 days of treatment. Exact positioning of Molnupiravir in India. Molnupiravir should be used for all elderly patients with comorbidities. Molnupiravir must be used in all healthcare providers if there are no contraindications. Molnupiravir can be used in young patients also, because 5 days treatment does not give you any side effect. Extremely safe, provided they have risk factors. Don't use it for all garden variety cases, because in most of the cases you don't need any antiviral. But yes, if you need antiviral, Molnupiravir can be a good option. If patient would recover with antibiotic and paracetamol, Molnupiravir is not required. That was Dr. Punchi's question. Any variant, yes, Molnupiravir with its unique mechanism of action makes me feel that even if there are future variants of interest and variants of concern, this drug is likely to be useful.
But as Agam, to comment on what, and Dr. Gifty, a champion of virology, is here with us. He will always tell that if at all the virus or any virus, forget about COVID, they will mutate in a process of, look at the speed of the mutation, the speed of the reproduction that they have. How can you expect that with that speed, you will not get the variations and mutations? In fact, two identical twins are not same, while they are just two things which are coming up. So
yes,
the mutations are going to be the part of evolution of virus or attempt to survive, as all the living beings have a choice to and have a right to survive. Even the viruses, even though they are not characterized as living organism, but they are everything which can probably possibly multiply, has a right and right to live. So probably mutations you should not be. Why we were probably following these mutations? Because we wanted to be ready. There was so much of suddenness in the disease, and that was the reason why we kept on following the various mutations, and we started talking about that. It was not to really know about what is going to happen in the future. It is just because there has to be some readiness, which we were not, at the onset of pandemic. Correct. And one question haunts my mind, Agam, and I wanted to ask you and also Dr. Gifty that, if you remember in the height of the pandemic of Delta, while we were waiting and the labs were giving reports, 48, 72 hours later on, there used to be queues waiting outside the lab for even the RT-PCR testings. So that time what we did was, whenever there was a strong clinical suspicion or an evidence, we started these patients on with favipiravir or antivirals, and then probably if the patients they tested negative, we de-escalated, we stopped it. Can this be done for Molnupiravir as well?
Yes. I mean, I'm in complete agreement. And Dr. Gifty, we had a paper which we published in JIMA. I don't know, did we discuss that last time? It was published in the Journal of IMA, and we said this was published probably Mangesh kabhi May or June mein aaya tha na apna? May or June last year we published, and we said, I'm not talking of Mumbai, I'm not talking of Delhi, I'm not talking of Chennai, I'm talking of India. And in situations where your RT-PCR is going to take time, in situations when there is reluctance in doing RT-PCR, and when there is high clinical suspicion. So during this pandemic, mark my word, during this pandemic, any fever which presents as influenza or present as COVID must be treated as COVID, and you could always initiate antivirals as required if situation demands. And you could revise your decision once you have reports in hand. So after 3 days, suppose if you get reports which are negative, or after 3 days your patient does not behave as COVID, and you realize, oh, it was malaria, you realize it was something else, so it's atypical pneumonia, probably you can revise your decision, you can stop treatment at that stage. You don't need to continue full 14 days. We were talking about favipiravir at that time. You don't need to continue all 14 days of favipiravir. You can stop it at 3rd day, but don't, because unless you start early, you don't get good result. That was the thought process behind. So Dr. Gifty, your views on it.
Yes, that's a fantastic viewpoint. I can share a lot from HIV. We have had cases which had near exposure to HIV or suspected exposure to HIV, and we didn't know the partner source, which was HIV positive or not. And these were mostly sexual exposures. Middle of the night, we get calls, and we immediately start them on empirical antivirals. Immediately, a cocktail of 3 drugs. Like raltegravir or dolutegravir, which is inhibitor, integrase inhibitor, with tenofovir and emitricitabine. And later, we get the best of nucleic acid testing within the next 2 days. And if the viral load is 0, no transmission. And if the patient is negative, we rapidly de-escalate the patient.
Exactly, that's what.
Nothing happens. This is a beautiful strategy. We are using an antiviral as an elixir of life at a point in time where that 48 hours is all it takes for HIV to integrate into your genome. And any amount of drugs given after that.
Snail is jump out of the screen and grab or next time we talk about this.
Yes. So
great. So
Yeah,
I think
post-exposure prophylaxis for COVID is definitely required, especially doctors entering COVID wards suddenly break in PEP and other things. Some kind of prophylaxis is required on top of the basic vaccine backbone.
correct.
Yeah.
I think that brings us to the end. I can see one interesting question: on which day of infection to start Molnupiravir? See, Molnupiravir must be started as soon as you have a confirmed case, elderly with high risk. As soon as you have, clinical suspicion in high risk. Whenever you have a patient with comorbidities and multiple issues, elderly, immediately you can start. But if you have young patient and if patient does not respond to your conventional line of treatment, say you put him on symptomatic treatment, day 3 fever does not settle, probably these are the candidates also to consider for Molnupiravir. So Molnupiravir should be started as early in elderly patient with comorbidities. In young patient with garden variety infection, probably you can wait for 3 days. If fever does not settle, or if he gets another symptoms or new symptom development, probably that is the time to add Molnupiravir. Thank you very much. I think it was
There's
a
one more
great
question,
learning.
Agam.
We
There
had,
was one
yes.
question which was by Dr. Arjun, I believe. If the patient tests positive after 5 days of therapy of Molnupiravir, now what will you do? So believe me, Dr. Arjun, patients are going to test positive because the test kits are going to detect even the smallest viral fragments as well. Because if you really remember, the RT-PCRs are designed to pick up the genes of the viruses. So in spite with, and it does not tell you about the transmissibility or either the livingness or the possible ability of reproduction of the virus. So doesn't matter at all. More importantly, look the patient clinically, examine the patient clinically, take your clinical decisions, be watchful, and follow up these patients properly. Once these patients have received full course of any antivirals, it's very unlikely that these patients are likely to be patients who are responsible for the community transmission, because their infectivity goes down significantly. And over a period of time, as a natural course of recovery of any viral disease, as far as or any RNA type of virus disease that we have, well, most of human beings will respond in the same way that all the other viruses they respond.
Great. And if patient is still symptomatic at the end of 5 days, 6 days, 7 days, do keep in mind they may have a hyperreactive phase, they may have an immune phase, and this may not be a Omicron variant, it may be a Delta variant,
second possibility
it may be a
of
secondary infection, it may be a
or
long COVID. There are so many
diagnosis.
things you have to keep it in mind. But what Dr. Tivaskar said, sputum positivity or RT-PCR positivity after 5 days, whether if patient is asymptomatic, does not matter. You don't need to continue treatment beyond 5 days. There are no studies, there are no documents which say that Molnupiravir beyond 5 days is required in most of the patients. I think I bring you to the end of this program. I must thank Dr. Gifty and Dr. Mangesh Tivaskar for your time. I must thank IGCP. I must thank Reddy's for giving us this platform. I must thank all of you who spared your Saturday evening to be with us.
Before Agam says anything, again my turn. Let us put our hands together for wonderful moderation. And with the charm
moderation
and
is the simplest job,
Charm and
I use delegate's name to get all my queries sorted, and there cannot be any better opportunity than this to get all your doubts clear. And I must thank you for this crystal clear answers. Before I wind up, one take-home message from Dr. Tivaskar to begin with you.
Yeah, it was. In fact, Molnupiravir is one of the promises that we have. Maybe, that cheap, easily available slowly, as many companies will start coming out with, including Reddy's have already come out with it. And of course, affordable and very short course. Use correctly, try to utilize your clinical sense while choosing the therapy, and try and follow the protocols which have been laid down by the government or the guidelines affiliated or bestowing associations, maybe the national or international or multinational. Follow the guidelines and probably you will succeed in managing your patients very well.
Great. Dr. Gifty?
Yeah, I think Dr. Mangesh said it so beautifully. I have only one thing to say. In a viral pandemic, there should be no hesitancy in using an antiviral.
Perfect.
It is a holy grail of the virus pandemic itself. Rest all are supportive drugs. It is as simple as that. And Molnupiravir remains a very promising antiviral.
Thank you very much.
As beautifully said, and in infection, you never think about, boss, shall I use antibiotic or not, when there is a documentation on the infection.
So easily we prescribe antibiotic, even if we know it's not a bacterial infection. Yes. But when it comes to antiviral, we don't have to be so choosy. Evidences are there, but there's nothing like experience-based medicine. I request all of you to use it in a few cases, few needy patients, and you will see the results. And these results would add to your confidence. Dr. Gifty, I came across a very beautiful study, and let me quote. This study says that people who have more birthdays, there is a very beautifully conducted double-blind study which said people who have more birthdays live longer. So interesting study. So every study comes with a pinch of salt. Don't get very choosy. Don't get carried away by these studies. Use these molecules in the right clinical scenario, and I'm sure you will see success. Thank you very much. Thank you. And over to you, ladies.
Yeah, thank you very much. Thank you, Dr. Agam, Dr. Mangesh, and Dr. Gifty for this brilliant presentation. I can say that the key messages are very well percolated across all the doctors who are attending this session. Thank you once again. Thank you, IGCP, for conducting this, and which is very well supported by Dr. Reddy's. And before we end, I would like to thank even all our delegates who are attending this program. Thank you very much. Stay safe, stay healthy till we meet next time. Thank you.